40 years old female patient presented with sudden headache accompanied by visual impairment.
Sir, should I start?
Yes.
Okay,
Any
I'm
candidate,
present.
any candidate who wanted to the screen, the control, let's
Okay, sir, I'm
request it.
requesting. Sir, I have requested it.
Okay.
Okay. So I am provided with T1 sagittal images, non-contrast of a 40-year-old female patient who presented with headache. And the obvious abnormality I can see on the sagittal images, there is marked enlargement of the pituitary gland is noted, and hyperintense signals are noted in the pituitary gland with its expansion. And I cannot appreciate uh, the posterior pituitary bright spot, and the anterior pituitary seem to be compressed by this hyperintense area. I would like to review this upon further orthogonal images. And sir, I would like to review it upon T1 axial and then post contrast. And sir,
Yes. I'm searching. There are no post contrast.
okay.
Okay. There are axial gradient.
Okay.
Go on. Mm.
Okay, upon the axial gradient echo, I can see that there is a blooming artifact noted in the cellar region. And now I would like to review axial T2 images.
Oh,
Axial T2
this is
axial.
axial flare. Mm.
Okay. Again, upon the axial flare, there are hyperintense and hyperintense signals layering within the pituitary gland are noted. Now, I would like to say my likely differentials would be that of pituitary apoplexy, some cellular lesion,
Excellent.
likely pituitary apoplexy. The vessels, the internal carotid vessels visualize appears unremarkable, which rule out the aneurysm.
Please,
And
doctor, please raise your voice. Raise your voice, please.
okay, sir. Okay, sir.
Yes.
So is it better now?
Yes, yes. Go on. Yeah.
Okay. So, sir, keeping with the imaging findings, I am suspecting pituitary apoplexy as there is hemorrhagic or hyperintense signals noted upon T1 weighted images, and the surrounding internal carotid vessel appears to be unremarkable. So, this is a cellular lesion with hyperintense T1 signal, and the post-contrast images are not available, and the internal carotid vessels, they are appearing unremarkable. Sir, I would convey my findings to the referring physician and refer the patient to the neurology department for further workup and management.
Excellent. What is the most common cause of pituitary apoplexy?
Sir, it's a Sheehan syndrome in the postpartum females. Uh, One of the causes that, and the pituitary macroadenoma can also leads to apoplexy.
Which type of macroadenoma?
Sir, mm, uh, adenomatous.
Okay. Next case, 10 years old male patient presented with recurrent attacks of weakness. You have the
Okay.
control.
Okay, sir. I'm provided with the T2 axial images of a 10-year-old who present with recurrent weakness. So as I scroll down, I can appreciate that there are multiple flow voids noted in the region of the bilateral basal ganglia, and I would like to review these on upon flare images. And upon flare again, there are multiple hyperintense signals noted along the bilateral basal ganglia, and flow voids are again noted. I would like to review it on the diffusion images to look for any diffusion. And there in the diffusion
Sir,
weighted
one minute.
images there are.
1 minute, please. Don't
Sorry.
open any sequence
Okay, sir. Okay, okay, I'm sorry.
because
Okay,
you
sir, I
can't
would
do
like.
like this in exam. Okay?
Okay, sir. Okay,
Yeah.
okay. I'm sorry. Sir, please
Okay.
open. Sir, I would like to review this upon diffusion weighted images, and in which I want to rule out any area of acute restricted diffusion, and I cannot see any area of acute restricted diffusion. Now, I would like to review it on MRA to look for
No
vascular.
MRA available. Could you give me differential diagnosis from This
Sir, keeping in view the imaging findings and the history of the patient, I can appreciate that there are many collateral vessels seen in the basal ganglia, and I
excellent.
cannot appreciate internal carotid arteries, the supraclinide portion of the internal carotid arteries. So I'm suspecting Moya-Moya syndrome. I would like to confirm it upon MRA to look for puff of smoke appearance,
Excellent.
which is
This is
sir. So
MRA.
upon
Yes.
MRA, I cannot appreciate supraclinide portion of bilateral internal carotid arteries, and then there is puff of smoke appearance noted, which are representing collaterals involving the bilateral basal ganglia. So
What's
it's
your
a
the
case
final
of
diagnosis? Your final diagnosis,
s-
doctor?
sir, Moya-Moya syndrome.
What is the difference? Is this Moya-Moya disease or Moya-Moya syndrome?
Sir, in the syndrome, I guess there are infarcts too. Sir, so this has to be Moya-Moya disease. I don't know exactly, sir.
Do you know the difference between them?
Sir, no, I don't know the exact difference.
No problem. Don't worry. We have remaining time, Dr. Kila.
30 seconds left.
Okay. Thank you, doctor, so much. Really,
Thank you, sir.
uh, really, you are amazing. You did very well. Why I ask him don't open any sequence because this is the actual exam. The examiner will show you this only. And sometimes when you request whatever you want. Okay. But sometimes the examiner will tell you this is the only available. Give me a diagnosis from here. Okay. This is
Okay.
point. Second point,
Yes, sir.
anything, please, يعني, take a permission from the exam. As you see,
Okay, sir.
as you said here, there are multiple collaterals here, okay? Plus, there are white matter abnormalities, okay? This is the only point you forget to talk about.
Yes, sir.
There are here all the infarction or area
You
of
mentioned about flare,
encephalomalacia.
but I forgot on yes to T2.
No problem, no problem, no problem. Okay, and you did very well when you asked about the MRA. See, absence or markedly attenuation of the terminal part of internal carotid artery in both sides, as well as the terminal branches, ICA, MCA, surrounded by extensive collaterals. Please, I am waiting to listen from you, puff of smoke, but no problem. You did very well. The difference between Moya-Moya syndrome and disease. Moya-Moya disease is idiopathic, okay? But Moya-Moya syndrome secondary. Don't forget, S with S. Syndrome is secondary. Secondary to what? To any multiple connective tissue disorder. NF1 or 2, neurofibromatosis. Many types of vasculopathy, fibromuscular dysplasia, radiation-induced vasculopathy. Don't forget. Okay, my colleagues. Case number 1, you did very well. This is T1. This is bleeding or fat. So we see here, this is this is flare. This is fluid level, not layering. Okay. You need to use always the buzzword. You said this is layering. Okay, correct. But this is fluid level, a radiological term. When I show you this one, this is a blooming artifact. So this is bleeding. Your diagnosis were very correct. This is pituitary apoplexy. Pituitary apoplexy means hemorrhage within the thyroid. The most common cause is a hemorrhage within a cystic pituitary macroadenoma. A hemorrhage within cystic macroadenoma. You tell something not correct. Sheehan syndrome. Sheehan syndrome is completely different. Sheehan syndrome is post bleeding, يعني generalized bleeding, causing generalized hypotension, causing ischemia to the pituitary. This is a different pathology, a different pathway. But يعني don't worry. Okay, you did very well, doctor. Um,
Thank
second
you, sir. Thank you
candidate,
so much.
welcome. Second candidate,
जी अस्सलाम वालेकुम सर
alaikum salam. Request the control, please. 10 years old
सर
male patient. Yes.
Sir, could you please scroll for me? I don't have that.
Okay, no problem. 10 years old male patient presented with diplopia, progressive left-sided weakness, headache,
Okay,
and no past history.
Okay, I'm provided with the axial MRI FLIR sequence of a 10-year-old child who has left-sided body weakness. I can appreciate an abnormal signal intensity area predominantly involving the deep white matter of the posterior parietal region. I can see multiple flow voids within it. There is no significant, the edema is the hyperintensity is crossing the midline, and I can also see some serpiginous linear hyperintense areas within it. It is crossing the midline, however, no ventricular dilatation or no ventricular dilatation is seen. So I would like to see GRE or post-contrast sequence.
This is post-contrast?
Yes, on post-contrast images.
I don't know what happened. Oh, it is still loading. Download. Okay. Let's see if DWI.
Yes, on DWI weighted sequence, I can see no significant restriction.
Yes.
I would like to confirm this finding on the
Are you
ADC map
sure,
as well.
Doctor? Are you sure?
Sir, there are few areas of restriction. Yes, that could be infarcts. That could be acute infarcts with an area of atriovascular malformation in this region.
What will you do next?
Sir, I would like to do angio of this patient, CT angio or MR angio, MRA.
Why? Why? Compare with ADC. Why you didn't want to compare with ADC?
So to confirm that this is an infarct and that and it is not a T2 shine through phenomena.
Yes, sir.
Yes, I can see this is confirmed. Yes, sir, this confirms infarct. The ADC, there are low ADC values in this region. I can see hypointensity in that region.
Where is the hypodensity here? Central or peripheral?
Sir, peripheral hypodensity, yes.
Yes. So the restriction here, peripheral. Okay?
Yes.
Okay. So what's your provisional diagnosis?
Suppose post-contrast sequences, I would like to confirm my findings. This is likely a case of vascular malformation with the adjacent area of ischemia and infarction.
What else? I don't know what happened here. It needs some time to download. Suppose that there are mild contrast uptake. What's your provisional diagnosis?
So this is likely a vascular malformation. So this could be any venous anomaly or arteriovascular malformation.
What else? What else?
So it could be vein of Galen.
Would you think this is the expected location of vein of Galen malformation?
No, sir.
This is in the corpus.
Not the location. Yes.
See, there are faint contrast uptake or minimal. Okay. What else? Yeah. Connect the informations, what you said, with each others. Tell me on.
Some multiple flow voids are seen in the periphery as well as in the central area. These are likely
no flow
vessels.
Voids. Doctor, no flow voids. This is just blooming or cystic changes inside.
Okay.
Why? See, look at the T2. Where is the T2? Or the ADC. ADC show me this is, what is the ADC?
So this could be a demyelination process.
Demyelination
process with.
See, this is cystic changes. What else?
So this could be a mass lesion with.
Yes. So, give me differential diagnosis.
So ganglioneuroma or DNET.
Excellent.
That has a central bubbly appearance with the cystic changes.
Okay. Excellent.
Crossing the midline. Crossing the midline. Yes, sir.
What do you want to exclude here? Like I said, 4 points you should exclude in any tumor case in brain. You told me there are no hydrocephalus. Excellent. What else you should exclude?
There is no brain herniation. There is no
Excellent. What else?
tonsillar herniation in the current examination.
Excellent.
Sir, there is no significant enhancement of the dura or the pia mater as
More
well.
than excellent.
So,
Excellent. Thank you, doctor. Which MDT would you transfer the patient?
sir, I would like to, sir, neurosurgical MDT for further evaluation.
4 years old female patient presented with seizures.
Okay, I am provided with the MRI T2 weighted sequence axial slices. I can appreciate there is lobulated nodular areas outlining to ventricles.
Yes.
That is isointense to the gray matter.
Yes.
So likely gray matter heterotopia. Gray matter heterotopia.
What's your differential diagnosis?
So gray matter heterotopia differential diagnosis would be, sir, tuberous sclerosis plaques that can also give this baby appearance of
what
the
else? What else?
So on post contrast, no significant enhancement is noted. That further confirms the diagnosis of gray matter heterotopia.
Okay, excellent. What will you do next?
Sir, I would like to refer this patient to the referring physician. I will inform my finding to them, and sir, no significant hydrocephalus or other any abnormalities seen within the visualized brain therapy.
Thank you, doctor, so much. You did very well. Don't worry about the first case. This is the usual. All of us startup case, even it was very easy. All of us struggle sometimes, but don't worry, you did very well, especially in the second case. This is a case of subependymal nodular gray matter heterotopia. Okay, the differential diagnosis should be tuberous sclerosis. How can we differentiate? First point, there are no calcification. We can detect it in the either SWI or the gradient. Second point, the tuberous sclerosis has more extended than the subependymal affection. It has many subcortical and cortical signal abnormality, at least tubers. Okay, this is one of the confusing point for most of us, how to differentiate between both of them. Heterotopia is limited to subependymal, almost. But tuberous sclerosis extended disease involve most of the brain, cortex, cortical, white matter abnormality, and you can find sometimes SIGA, subependymal giant cell tube. Okay, what will you do next? We will transfer the patient to neurology, pediatric neurology, MDT. Okay, maybe family counseling, genetics, all of this. Thank you, doctor. This case,
thank you so much.
This case is little bit confusing. Why? Due to the age of patient. So, but my colleague, I want to tell you, this is the FRCR-Viva true scenario, actual scenario. He gives you pathology in non-usual age or non-usual location. Usual pathology or for uncommon age. This is a young 10-year-old.
Yes.
So it was so confusing, really. But see, there are signal abnormality here crossing the midline. You start very well. You should go behind your doubts. What is this? There are some cystic changes. So see, some cystic changes, and this is very big. Okay, you can put your in your differential diagnosis demyelination, but this looks like mass with cystic changes, especially after I showed you this DWI. There are peripheral restriction. Again, because this is confusing, there are peripheral restriction which confirmed by ETC. and the central facilitation, which also confirmed by EC. So this looks like mass with central necrosis. Okay, put on your first in the top of your differential diagnosis list a mass, whatever it will be in the pathology, but mass. Second, okay, demyelination, infection, but less likely to see infection, especially I didn't give you any history of fever. Diplopia, progressive left side. Progressive means chronic. So when the examiner are showing you the history, try to pick up, concentrate in each word. Progressive means chronic. Thank you, doctor, so much.
Thank you so much.
Candidate.
Yes, sir. Salam alaikum.
Salam.
Can you scroll for me, please?
Yes, 45-year-old, but take care, my colleagues. In the exam, you should scroll. No way. Okay.
Yes.
45-year-old female patient presented with headache and right hemiplegia.
I'm presented with axial cuts of flare sequence brain MRI showing abnormal signal intensity involving the white matter of the left temporoparietal lobe.
Yes.
There is no any other abnormality seen in the provided cuts. The central somia valley are normal. There is no hydrocephalus. I want to check the other sequences, including the T1 and the diffusion sequences.
This gradient.
Okay, in the gradient sequence, I can see that there are foci of blooming within the abnormal signal intensity area. And I want to compare with the T1 sequence to check if it is high signal or not. In the T1 sequence, there is the abnormal signal intensity area is of intermediate signal in T1. I cannot see any abnormal high T1 signal intensity. I want to check the diffusion sequences and
sure,
the post-contrast.
No diffusion, doctor. No post-contrast. Are you sure there are no any hyperdense signal here?
In this cut.
What are you thinking?
Sorry?
What are you thinking about?
Based on the location of the abnormal signal intensity and the blooming, I was thinking about an infection with hemorrhagic changes.
What else?
Infarction with hemorrhagic changes is less likely because it is not of arterial territory.
Are you sure?
And
are you sure?
Okay, I may think about the posterior cerebral artery territory as it was posteriorly located. But I can see that there is increased signal intensity involving the left transverse sinus.
Excellent. So, what's your
So
differential?
I'm thinking about differential. First will be a venous infarction with hemorrhagic changes due to transverse sinus thrombosis.
Okay.
I want to convey my findings urgently to the referring surgeon. The patient should receive the treatment, anti-thrombolytic treatment, and to be followed up.
Transfer the patient. Do you want to do anything in your department?
Yes, MRV. Yes, I want to do MRV. And this is the contrast enhanced T1 showing filling defect involving the left transverse sinus and extending also to the sigmoid sinus and the jugular foramen as well.
Jugular vein. Okay, excellent.
Yes.
So your differential is?
It's cerebral dural vein thrombosis with the venous infarction of the left occipital lobe.
Could you tell me the cause of this infarction, of this venous thrombosis from this MRI?
The cause I am because of the proximity of the sinuses to the left mastoid air cells. I want to check the mastoid air cells, and I can see that there is increased signal intensity in the left mastoid air cells. Could be the needles of infection, mastoiditis.
55 years old female patient presented with altered consciousness, fever, neck stiffness, and lower limb weakness.
Okay. I'm presented with the flare sequence MRI of the brain, axial cuts. I can appreciate that there is a blooming signal, or there is a low signal intensity involving the right lateral ventricle, and involving also the sigmoid, the straight sinus, the low signal intensity is seen to a lesser extent involving the left lateral ventricle as well. To me, it seems to involve the choroid plexus of both lateral ventricles.
What
And
else,
there are
doctor?
also linear.
Don't worry about this. There are one critical result.
Yes, there are low signal intensity involve the sulci of both cerebral hemispheres as well. This may be concerning for the presence of subarachnoid hemorrhage.
Okay.
So I should check the other sequences, although the flare sequence of MRI is the most sensitive. I want also to review the MRA for any possibility of aneurysm, rupture aneurysm.
Doctor, what is this?
This is left side subdural collection, fluid collection.
And
it causes mass effect on the left cerebral hemisphere. Yes, and with mild midline shift, I should look for the possibility of a subfalcine herniation.
Excellent. What
there
else?
Is a mild dilatation of the right lateral ventricle, possibility of subfalcine herniation. I want to check the MRA or post-contrast images for any possibility of vascular. Yes, the diffusion weighted. Yes,
this is the post-contrast.
This is the post-contrast. The collection appeared to have peripheral enhancement. So I want to correlate with the diffusion sequence.
No diffusion. What's your differential diagnosis according to the patient history?
Yes, the presence of fever and peripherally enhancing extraaxial collection. I'm thinking about empyema, left-sided subdural empyema.
Complicated by?
Time is up.
Okay.
This is complicated by.
Yes. Complicated by what?
By midline shift subfalcine brain herniation. This is the diffusion restriction, and there is also a focus of infarction in the right basal ganglia.
Thank you, doctor, so much. Let's revise.
Thank you.
You did very well, but my colleagues, please, when any examiner bought one film, show you one film like this, there are midline shift, there are one emergency finding. Start with it. Don't what is the value? See, doctor, by the way, you did very well. Okay, but let me give you, all of you, some notes for the exam. Please start with this emergency. This is very obvious midline shift. See, if you told me there are, doctor, one critical result, midline shift, there are a mass effect from the left side and almost associated with subfalcine herniation. You are very good. Doctor, I could remark some abnormal signal here. Looks like collection here. Could you show me T2? Yes. Oh, doctor, this is collection. In the beginning, you go in very wrong pathway. This is subarachnoid hemorrhage. I will check MRA, aneurysm, and in the beginning, the patient has fever. Okay, take care, my colleagues, to go in the correct pathway from the first second. Okay, then this is the diffusion, restricted diffusion associated with this infarction, like infarction in the right basal ganglia. Okay, especially this is the globus pallidus. This is sorry, the butamen. This is the globus pallidus. Okay, so this is infarction. What happened here? The compression caused in this site as you see, peripherally enhanced collection here. This is empyema, and the mass effect shifting to the contralateral side. Subsequently, there are some ankle herniation maybe, or anyway, there are some compression here at the right-sided vessels, so complicated by this lacunar infarction. And this is the actual and the scenario of the FRCR. It will bring you something very obvious, and then what happened? He will give a tricky finding. Why? He wanted to be sure that you are safe radiologist. You revised everything. This is very important. This is very important, my colleagues. Okay? This is very important to pick up every finding. Take care of satisfaction of search. Case number 1 for you. This is signal abnormality here. Okay, in non-territorial, you are very good like this, and then you see some blooming artifact. Very good. So this is either a mass with hemorrhage or hemorrhagic infarction. If you told the examiner in this manner, in this philosophy, he will be very happy. Okay, despite you should, when you see something hemorrhagic here, you should have an eye of eagle. Is there are any signal abnormality here? Yes. Doctor, could you show me T1, please? Don't ask for other MRA, post-contrast before you revise all the conventional sequences. Doctor, see, you take too much time, doctor, to see this, and I'm scrolling up, down, and you absolutely said with and you were very confident there are no any high T1 signal. Okay, I think you means here. Okay, but look here, the key is here. What is this? This is the left transverse sinus. Okay, transverse, then sigmoid. Okay, then to the jugular. Oh, this is very extensive venous thrombus. Okay, before you finalize the case, tell the examiner, doctor, please show me T2 axon. Oh, doctor, there are automastoiditis here. There are automastoiditis. This is the cause. Thank you. I will give you full mark. Take care, doctor. You did very well, but in each step, you are waiting me to give you a hint. The examiner will do like this, but he will demarcate you. Okay? My colleagues, FRCR is exam of nerves and exam of procedure. All of you have a very good knowledge, but the hot seat is very hot for your adrenaline. Second, we forget what is the treatment. Practice. Which type of practice? Practice under stress. Thank you. Next candidate, please. Next candidate.
Yes, sir. Yes, sir. Assalamu alaikum.
Salam. Do you want control?
No, sir.
Okay. 40-year-old female patient presented with headache.
40-year-old patient presented with history of right breast cancer. These are axial sections from
Sorry,
T1
sorry, the examiner will not show the history in this case, but by mistake I put it. No problem. Yeah, go on.
Okay. These are axial sections from T1 weighted MR brain images. There are multiple altered signal intensity lesions are noted in bilateral cerebral hemisphere, cortical and subcortical location, predominantly in
Yes.
gray white matter junction.
Yes.
On on SWI images, there is a blooming artifact noted in one of the lesions in the left occipital lobe.
Yes.
No significant brain parenchymal edema, mass effect, or midline shift is noted.
Excellent.
So
Which
so
sequence
one of
do you
these
want to
lesions,
see? Which sequence do you want to do?
I
Choose one
I
sequence
want to
only.
see
Mm.
sagittal flare or post contrast.
Which of them and why?
I want to see the contrast enhancement.
Why?
To rule out any if there is abscesses or any metastatic deposits. So on post-contrast images, these lesions show post-contrast enhancement. They are involving the supratentorial as well as infratentorial locations. These lesions show some of these lesions show internal cavitating areas.
What's
However,
your
the enhancement
differential?
is
What's your
most
differential?
like the patient is a known case of cancer, so most likely differentiate, and also the position of these lesions on the gray-white junction. The most likely diagnosis is metastatic deposits. Other differential possibilities could be infective abscesses,
Could you tell
likely
me?
tuberculosis.
Could you tell me which type of metastasis? This metastasis?
One of these lesions show blooming artifacts, so these can be hemorrhagic mets.
What is the? Could you enumerate some primary for hemorrhagic brain metastasis, please?
For for hemorrhagic brain metastatic choriocarcinoma, as well as uterine carcinoma, osteosarcomas, and breast cancer.
What is the most highest rate of hemorrhage? Came from which primary?
Choriocarcinoma?
Okay, no problem. 35-year-old male patient presented with headache, convulsions for 3 months. History of shunt tube insertion.
35-year-old male patient presented with headache and convulsions. These are T2-weighted MR axial sections, brain. There is an altered signal intensity area noted in the uh, parasagittal location in relation to the third and fourth ventricle,
What is the
causing
exact location? What is this region? What is the name of this region, please?
pineal region.
Excellent. Excellent.
It is in the pineal region, and it is causing. I will like to see the sagittal images to know its to see its effect and relations.
No sagittal images. This is only diffusion.
Okay, it is causing it is showing restricted diffusion on diffusion images, as it is bright on DWI and low on ADC images, in keeping with the restricted diffusion.
What's your
So
differential
I will also like
diagnosis?
these can be pineoblastoma or pineocytoma. I will like to see its T1 weighted or CT images to see whether the calcifications are present. If the calcifications are peripheral, the most likely differential would be pineoblastoma.
CT done and they show no any calcification. Look at this. Tell me what is this? What's the type of this sequence? What is the name of this sequence, please?
This is T1 post contrast.
So,
and it does not show any post contrast enhancement. So
what's your
it can be any epidermoid cyst. It can be epidermoid cyst, as it shows a restricted diffusion, or
what will you do next?
I will see whether it is only causing minimal hydrocephalus. I will inform the referring physician and recommend urgent neurosurgical review.
Is this
For further
cyst
management.
ruptured? Is this cyst ruptured or not?
Sorry?
Is this cyst ruptured or not?
Rupture. Okay, I will see the other images to look.
No, from diffusion, tell me, please.
Okay, then no area of restricted diffusion noted in the ventricles or subarachnoid spaces. However, I will like to review whole of the study.
So finally, rupture
Uh,
or not?
Time is up.
Thank you.
Slightly, there is, I think there is rupture. There is rupture.
No rupture, doctor. You were right in the first. Why? There are no any intraventricular restricted signal. Also, even see, look at here in the sylvian fissures. Look here, the basal cistern. This is the most important sign. Here, I don't know if this inside or outside the fourth ventricle, but if this ruptured, he looks like irregular from the outside, and it may be early sign. Okay, but frankly, no frank rupture. See, this is advanced question to give you a higher mark. Thank you so much. You did very well. This is benign. My colleagues, see, because most of us confused between at the benign region in the axial. Very easy. What is this? Brainstem, especially this is midbrain. What behind any lesion behind? Think in benign region, biennial region. Okay, this is it could be and almost it will be a biennial region lesion. Right, in the suprasellar region, if you see any lesion in front of the midbrain, think in suprasellar lesions. I'm talking about the axial because in the sagittal it is very clear. Okay, you make a big mistake here. Restricted cyst with restricted DWI. Okay, and I bought you didn't ask for post context. Second, I bought for you, I show you the post context. Third, you make a differential diagnosis away from epidermoid. Both epidermoid, no any restriction in the brain with this appearance. Very characteristic, very unique. Okay, no any mass will show this is extensive restriction and no enhancement. I'm not against putting in the tail of your list other pinocytoma, whatever, but give me the first. Okay. Second, you forget to talk about this. What is this? Shunt. Okay, because we should tell first, like any devices, doctor, there are evidence of right frontal shunt, CSF shunt, okay, and both lateral ventricle are not enlarged, so it looks like it work well or functional well. Very good, because if this shunt blocked, it will be emergency. Okay, but you did very well. Like I talked before, for any case of tumor, ask for sagittal T2 to rule out tonsillar herniation. This is really borderline, very borderline here. Okay, so we should rule out tonsillar herniation and the other herniation, but here at least a tonsillar herniation. Case number 1, sorry, you did also very well. This is hemorrhagic metastasis of the breast. When I ask you which sequence you want, I'm waiting from you sagittal post contrast. Why? Roll out leptomeningeal or meningeal metastasis. Why? Breast is very common with meningeal spread. Very, very common. Okay, my colleagues. Thank you so much. You did very well. Keep studying hard. Next candidate.
Thank you. Thank you, Doctor.
Welcome.
Yes, sir, I'm ready.
See, my colleagues, anyone want to take the control, I will not ask again. Ask me directly. Do you want, or should I scroll for you?
Sir, please scroll for me.
Okay, 25-year-old male patient. There is an occasional sensation of numbness in the arm. Go on.
Sir, I can appreciate a small intramedullary T2 bright lesion with the T2 dark signal at the superior and inferior end within the spinal cord opposite to C4, C5 vertebral disc players. It is short segment. Can you show me
it is on axial to confirm if it's intramedullary and post-contrast sequence. Yeah, the lesion is intramedullary and
Yes. What's your differential?
so can you show me the sagittal T1 post-contrast?
Vaginal T1 post contrast. What's your differential diagnosis?
The screen is not moving.
Could you see my screen?
Yeah, now I can see that. Okay, on T1 post-contrast images, I could appreciate subtle enhancement. There is no significant surrounding edema. I could cord
Yes.
expansion. So considering the imaging appearances, I am thinking of intramedullary spinal tumors. The
Yes.
possibility of this being multiple sclerosis or edema appear less likely because of the post-contrast enhancement, small size lesion. And as there was T2 low, superior inferior cap, my first differential would be an ependymoma.
What
And I
else?
would like to
Doctor, is this cap?
other would be hemangioblastoma because there are few hemangioblastomas. There are few flowoids within it, and
Is this cap? Is
other
this cap
differential
or
would be
something else? Doctor, is this cap or something else?
I,
This is
I
surrounding.
think it's the hemosiderin cap. I'm not sure.
Cap
Yeah,
is
then
here,
it's a
but this is
capsule. Maybe
surrounding. So
it is
not cap.
an encapsulated lesion.
Okay,
Okay,
give me another differential.
so other differential would be astrocytoma, hemangioblastoma,
What else?
METs,
Okay, but see, there
lymphoma,
are
but
very
very
characteristic
rare.
benign lesion which has
Oh,
nearly complete ring.
maybe T2. Okay.
Yes,
T2 low limits and the cavernoma. Cavernoma.
excellent. What will
Not
you do
sure. I have
next?
never seen a cavernoma, intraspinal cavernoma.
No problem.
I
What
would
will you
like
do
to
next?
inform the neurophysician, neurosurgeon. I
Before
will
you
inform the neurosurgeon.
before you inform, do you want to do any investigation for the patient at your department?
mm,
This is cervical cord cavernoma.
yeah, I would
Do
like
you
to
want
see the
to?
brain for any. Yeah, I would brain. I would like to review the brain.
Thank you. Excellent. 80-year-old male patient presented with right facial numbness, right hemifacial numbness, right hemifacial numbness. Go on.
Okay. I'm provided with the T2 sequences of MR of an adult patient, and I could appreciate significant cortical atrophy. The ventricles appear dilated, mild periventricular seepage is seen. Sir, can you please scroll down? I appreciated something. No, in the region, yeah, stop there. I could appreciate ISO intense T2 bright mass at the level of the Meckel cave and in the prepontine region, abutting the fifth trigeminal nerve. Can you show me the post-contrast sequences or the six sequences?
Okay. What's your differential
So there's
diagnosis?
a significantly enhancing lesion located in the prepontine region, extending into the Meckel cave, and
Yes.
it's along the fifth nerve and might be
Mhm.
compressing it, and maybe the cause of symptoms. Now,
Yes.
I'm thinking of my differential would be any aneurysm of the vessel or meningioma or schwannoma.
Okay, excellent. What will you do next?
I will inform the primary doctor and take a neurosurgery consult.
Before you inform the doctor, do you want to revise the examination for any associated finding? Do you want to
Yes.
exclude anything? What do you want to exclude here?
I would like to see both seventh and eighth nerve canals to see any concurrent schwannomas and
Excellent.
cerebral convexities for meningiomas.
Yes. What are you doing? What are you excluding now?
I'm
Which
excluding
disease?
NF2,
Excellent. Time is up, Dr. Akila.
Neurofibrosis.
Okay, excellent.
30
Excellent.
seconds.
30 seconds. Thank you, doctor, so much. You did very well. When the examiner, what I did here, when the examiner bought one slice and either he told you, no, look at here, the answer is here. Okay, you should examine the review areas, everything here. Okay, you start very well by very obvious pathology. But my colleagues, don't expect in the FRCR, he will bring one case for senile changes, preventricular leukomalacia, something not urgent, not of significance. Okay, he brings something. This type of exam, this is observation. Why? Because it is at the skull base. Oh, doctor, there are asymmetry here. There are a mass here in the expected location of trigeminal, or like the doctor said, in the Michaelis cap. Very excellent. And then doctor immediately give me, after you saw this post contrast, avid enhanced my differential. Second point, differential. If you wanted to exclude, like I said before, exclude because this is a skull based lesion, exclude any distraction. Okay, this is point. And another point you did very well. When I asked you, you told me, oh, I wanted to exclude other signs of NF2. But the mistake here, you wait me to ask you. Okay, my colleagues, try to proceed the examiner by one step. Try, my colleagues. Case number one, this is not cap. This is not cap. See, this is circumferential. This is ring. And in addition to this looks like popcorn, berry, whatever. There are multiple heterogeneous T2 inside. This is very characteristic for cavernoma. The cap, this is not cap. The ring, this is hemosiderin ring. And the T2 heterogeneity. Look at the T2. See, some high, some iso, some low. Okay. So this is a spinal cord cavernous malformation or cavernoma. Differential ependymoma, but ependymoma has only cap. Second, look at the post contrast. See, this is minimal enhancement. Ependymoma. Take more contrast, moderate or marked contrast. What will you do next? I will do brain to rule out other cavernoma and developmental venous anomaly. And developmental venous anomaly very associated with cavernoma in brain. I know. But multiple cavernomas is very, very associated with developmental venous anomaly. Second, when this cavernoma any bleed in within its tissue, it make a very severe pain. It leads to neurological symptoms. Next candidate.
Assalamu alaikum, sir.
Salam. 65-year-old female patient, follow up. This patient asymptomatic.
This is a CT brain plane of an adult patient in which I can appreciate the ventricle is dilated. It has a fluid level, hyperdense fluid level within it. I can also appreciate calcification along the fogs. There is a central midline calcification, and there are periventricular hyperdense. Sorry?
Yes. What type of this CT?
This is, sir, this is contrast delayed contrast enhancement.
Yes. So this is hyperdense, or this is?
These are all showing a delayed contrast enhancement along the ventricular lines.
Conclude what you said.
It is ventriculitis. It is ventriculitis. But,
this patient came Asymptomatic. What else?
I would like to know the history of any known malignancy or anything.
Yes. Why? What it could be?
It could be any metastasis.
Excellent. What will you do next?
I would do MRI of the patient.
Okay. This is MRI.
This is MRI gradient echo sequence of the same patient in which the area which was showing delayed enhancement on the CT scan are showing blooming artifact in the same region. It can be due to bleed.
Okay. This is the post-contrast. What's your differential?
Sir, these can be enhancing metastasis because the
can be, or this is surely enhanced.
Sir, these are metastasis because if the patient has a bleed or something else or infection, that would have shown some symptoms. So I would search for the primary or take the history or review the notes. I believe my topmost differential is metastasis.
Excellent. Which sequence you want? Only one sequence. You want me to show you? Choose one.
Sagittal T1 post-contrast.
Why?
To see the meningeal metastasis along the convexities and further the tonsillar herniation.
Excellent. What's your differential here?
Sir, I believe there is a thin enhancing rim which is irregular along the dura, and I think keeping in mind the rest of the findings, these are also metastatic deposits.
Don't worry about it because it is very thin. So, what's your differential?
Sir, my differential?
Yes.
My differentials could be, sir, if the patient was young, I would have considered any tuberous sclerosis, but the patient is old age.
What do you think tuberous sclerosis will enhance like this, doctor? What do you think?
No.
Give me a logic differential, please. What's your differential? This patient old age.
Sir, I'm not able to think any other differential.
You told me you told me metastasis. Okay, what type of metastasis? What type of metastasis here, doctor?
They are hemorrhagic metastasis.
Okay, versus what?
Sorry?
Which type of metastasis can do this hemorrhagic nature?
Sir, most commonly they are from lung, breast, and colon. Less likely colon.
No colon.
Renal
thyroid and melanoma. Thank you, doctor, so much. Thank you. This is thank you so much. You did very well. This is a brief intellectual melanoma. Why? Here, this one, blooming artifact or susceptibility artifact. Then when I show you this post contrast, this is a mass, not looks like nodule. يعني very thick nodular mass covering and including the ependyma. And see here, I think here crossing the midline, about to cross, and it is scattered. So this is metastasis. What type of metastasis came in the subependymal? Number one, lymphoma. Number two, you can do others. Beside, you can do, tell me, doctor, TB or ventriculitis, but the patient is not feverish. See, when you do a differential list, vote a logic according to this case, not according to Chapman, not according to Radiopedia. Okay. Second, there are, I think, the meningitis is normal. Why? It is enhanced, but very thin and uniform. You did very well when you ask you for sagittal post contrast to rule drop metastasis and herniation. This is the CT. If you didn't talk well and in the correct pathway about this CT, the examiner will not give you the MR. This is a subependymal, not hyperdense. Please, please look here. This is post contrast. The examiner will not show you. Look here. This is contrast. Look at the skull base. This is contrast. So there are nodular enhancement, subependymal enhancement in both lateral ventricles. Okay, this is very critical. I think here in the fourth ventricle there are something. This is periventricular metastasis, mostly melanoma. Okay. By the way, the susceptibility artifact here in melanoma. What is the pathology? Anyone know what is the cause?
Melanin.
What? Not melanin. Not melanin. Melanin didn't have a strong diamagnetic effect. This is due to bleeding. Due to bleeding. Melanoma is highly hemorrhagic. Okay, my colleagues. Thank you, doctor, so much. Next candidate.
Assalamu alaikum, sir.
Assalamu alaikum. Dr. Roshni or Dr.
Can you
Akila?
hear me?
Yes.
Hello, can you hear me, sir?
Yes, yes. You are Dr. Roshni or Dr.
Yes.
Akila?
I'm Dr. Rabia.
Ruby, welcome. Your voice is similar. Welcome, Dr. Rabia.
Okay.
Yeah, let's start. 2-year-old male patient.
Yes, sir.
2-year-old.
Sir, can you scroll?
Yes, yes. Presented with ataxia
Yes.
and vomiting.
Yes, sir. Sir, axial sections T1 of a 2-year-old child presented with ataxia and vomiting, in which I can see dilatation of the lateral ventricles, as well as there is I can appreciate a big isotense mass in the posterior fossa occupying the fourth ventricle. I would like to, that is causing secondary hydrocephalus, and it is extending into the foramen of extending via foramen of Magendie and foramen of Luschka. And it is also compressing upon the brainstem. I would like to see the sagittal as well as the diffusion weighted and the post-contrast images to confirm my diagnosis.
Yes. If I ask you to choose only one sequence.
Sir, it will be most probably post-contrast.
Which plane?
Sir, axial.
Axial? Okay.
Yes, sir.
This is axial.
Sir, I'm presenting contrast images in which I can see again the hydrocephalic changes secondary to the mass in the posterior fossa is appreciated. And the mass show heterogeneous enhancement. And it is occupying whole of the fourth ventricle. And it is also extending via, as I said before, foramen of Magendie and Luschka. And it is the parts which are enhancing are avidly enhancing. However, there are some non-enhancing parts as well, and there is high vascularity and enhancing vessels in the mass.
Yes. What will you do next?
Sir, I would like to do CT for the same patient.
No CT.
To see.
No CT.
No.
Give me only the next step for this patient, for his condition.
Sir, I would like to inform the neurosurgeon for immediately to decompress the ventricles and also inform about the mass because it is like yes, sir. And
excellent. 1-year-old male patient presented with large head, stigmas, and
yes,
tonic movement.
Tonic. Presented with the 1-year-old child sagittal T1 weighted images in which I can see. Can I go to the midline, sir? Can you go? Hello?
1 minute.
Sorry, sir?
Hello? 1 second. Because the voice
yes, sir.
get changed. Sorry. Again, my colleagues. 1-year-old male patient presented with large head, stigmas, and tonic movement.
Sir, sagittal T1 weighted image of a 1-year-old child presenting with the nystagmus and tonic movements, in which I can see, so there is in the T2 weighted images, there is diffuse white matter abnormality eliciting high signal, which is extending to the subcortical, involving the subcortical white matters as well. And there is no associated hydrocephalus and the gray matter and the deep gray matter, that is bilateral basal ganglia, they appear okay. This is most probably on looking at the first glance, my first differential will be leukodystrophy in this
Excellent.
case. And because of the large head, my first differential will be Canavans, because it always involves the subcortical white matters and associated with large heads.
Excellent. What will you do next to confirm or to exclude your differential diagnosis?
Sir, MRS to see the peak of sir, the
Yes.
Sir, NAA peak, to see the NAA peak, yes, sir.
Yes. Present. I'm presented with you.
Yes,
and
I'm
inform me.
presented MRS images that centered upon the white matter area of abnormality that shows the high
Yes.
peak of NAA that most likely suggests the diagnosis of Canavan's disease, which is actually one of the leukodystrophy.
What is the abbreviation NAS or NAA?
Sir, something acetyl, something that I don't exactly remember.
Excellent. No, don't worry. We have more time, Dr. Akira?
No, sir, it's up.
Thank you.
You can show me some. Okay, thanks.
Doctor, you did very well, really. You did very, very well and amazing, especially in the last case. Let me, my colleagues examine, because this is very
Actually,
ideal.
I am working in a pediatric hospital, that's why.
Okay, no problem. No problem. But this is one of the ideal answer. She found something here. I give her one unrelated sequence. She gave me the finding. Enlarged head. Thank you. Okay. And then I give her, she talk very, very logic and very, very organized procedures. Okay. She told me about everything, even the subcortical. But you didn't tell me the U fibers are affected. Okay. She talked about the white matter in the basal ganglia. Everything is affected. Plus enlarged head. My differential diagnosis would be Canavan, but I'm waiting for you versus mucopolysaccharidosis. I know there are a big difference, but for big head or for megalencephaly. Okay. Doctor, I want MRS. This is MRS. There are NAA, N-acetyl aspartate peak, because this is a metabolic abnormality in which this N-acetyl aspartate elevated due to absence or impairment of the catalase enzyme. Okay, so doctor, my provisional diagnosis would be a Canavan disease. My colleague, see, Canavan this one, NAA. Don't forget, Canavan, NAA. I know there are V, but try to drop it. Okay. Why? Because inside the exam, everything is confused. Very good, my colleagues. How to exclude this one from mucopolysaccharidosis? In mucopolysaccharidosis, there are significant or marked ventriculomegaly, very significant. Plus, you will not see this very white, this very high T2 white matter. يعني it will be something like cribriform pattern. Why? Because in mucopolysaccharidosis, the FRCR spaces are filled with mucopolysaccharidosis and subsequently widened. It has very characteristic appearance. So today, one home duty to revise and to train your eye to differentiate between mucopolysaccharidosis and Canavan. First case, you did very well, but you forget three very important finding or to talk about. You did very well, by the way, and you will take a very good mark. But I'm waiting from you to tell me a one buzzword there. This is extended to foramen of Lushka. Oh, see, this is a plastic ependymoma. The name, very good and very, very nice to tell the examiner. Second, I ask you which sequence do you want? Like I told you before, sagittal post contrast. Why? To rule out number one, drop metastasis. Number two, see the extension here. See my colleagues. This is very critical emergency. First, because there are severe hydrocephalus. Second, there are the tumor itself extending through the foramen magnum and markedly compressing the upper cord and the lower medulla and the cervical cranial junction here, or the cord and the medullary junction. I think this patient may be comatose. This is very, very significant compression. But here, doctor, see this point. This is the most critical. In flare, my colleague, or T2, anyway. What is this, my colleagues? In this slice, there are something emergency here. If anyone, yes, okay. What else? If anyone know?
Seepage?
What?
Seepage, sir? Seepage? Subependymal seepage?
Subependymal what?
Seepage.
CSF permeation. You mean this?
Yes, sir. Yes, sir. Permeation.
Yeah. This is one of the most important, very critical. Why? Means this hydrocephalus is under very high tension. See here? Here, very clear. This is very, very, the most urgent case in today's cases. Okay? I think this patient, if we didn't do a very, very detailed and very good report, he may die due to a radiology report. Take care, my colleagues. You did very well, my colleague. Thank you so much. Second, I think you take only 2 cases or 3? 2. Okay. Yeah. Second, next candidate, please. Thank you. Next candidate. Next candidate. Hello.
8 number is ready.
Next. Anyone ready?
Sir, I am. Candidate 7.
Yes, welcome.
Sir, I am candidate 9.
Let's start with 7. 7 is ready?
Sir, I already did.
7 is done, sir. I am candidate 9.
Okay, let's start.
Shall I say, sir?
Yeah. Can you see my screen?
Sir, I am doing candidate 9. Am I doing?
Yes. Yeah.
Okay,
Come.
sir. Yeah. Okay.
45-year-old female patient.
Good afternoon. Yeah.
Good afternoon. Do you want to scroll or do you want me to scroll?
Yes, sir. If you would scroll, it will be better.
Okay. 45 years. What, Dr. Akila?
Candidate 8 is there in the list. Why is not responding?
Let's start with candidate 9. Candidate 8, please prepare yourself after candidate 9. Please, my colleagues, be ready because we have 18 candidates today. I want all of you participate. This is according to your desire, and I am trying to do my best. 45-year-old female patient complaining of headache and vertigo 2 weeks ago. Yeah, let's start.
Yes, sir.
45-year-old female patient presenting with vertigo and headache.
Okay.
Yeah.
Okay. So yeah, yes. I've been provided with this MRI study Excel sections in T2 weighted sequence. I'm seeing through the images. Here I notice some abnormal area of abnormal intensity lesion in the scalp, in the soft tissue, extracranial. I mean,
don't worry about it. Don't worry.
Okay. Yeah. Okay. Then yeah. Then, can you scroll, sir? At this level, what in the left side, left side intracarotid, I mean, so left-sided ICA. I can see an crescent of hyperintensity around the along the vessel.
Excellent.
Then also there is an abnormal area of hyperintensity adjacent to it in the lower temporal lobe.
Yes.
Okay. Can you sir scroll? So.
What's your differential?
This is This is with this almost long segment eccentric. My differentials are. I am concerned about dissection of the ICA. Other possibilities of an intramural hematoma.
Excellent. What will you do next?
For this case, if CT is available already, then I would like to see the CT also to correlate for any hypertension along it. And also, I would suggest for a contrast enhanced MRI for further evaluation for this case.
No CT, no contrast MRI. Which sequence don't you confirm? Confirm from MRI.
I would like to see flare and SWI, I mean GRE images and flare both.
Do you want to see something else, please? If there are dissection,
T1 also, T1 weighted Excel.
Yes.
T1 Excel to see if any hyperdensity. Yeah. So this one is T1 Excel. Yeah. Let's see. There are some flow words also marked on the left side. Yeah. There is a bright foci adjacent to the bright foci surrounding the flow void of the ICS, so it is in keeping with possibly intramural hematoma.
Intramedullary hematoma of what?
Intramural hematoma of the ICF.
Okay. What is your differential diagnosis?
Differential was dissection of the ICA.
What will you do next?
After that, further evaluation by contrast MRI.
Okay, what will you do next?
I could not see any.
What will you do next, doctor?
In this studies, otherwise, I am not seeing any other abnormal foci. The rest of the brain parenchyma appears unremarkable. There is no altered signal.
How could you transfer or refer this patient to which doctor, to which specialty?
Yes, sir. Yes, sir. Yeah, this case is an emergency, and I will inform to the neurosurgical team and also the intervention radiologist for the need of any intervention, and also to the neurosurgical team.
Thank you, doctor. 45-year-old male patient presented with back pain, bilateral lower limb weakness, and sensory disturbance.
Okay, back pain. Okay. Yeah, this I've been provided with sagittal sequence of the T2 weighted MRI for spine, the thoracic spine. Here I can see abnormal tangle-like flow voids are noted in the extramedullary location along the spinal cord. This is concerning for spinal dural AV malformations. Sir, can you scroll?
Excellent.
Apart from that, the spine, the bony spine appears unremarkable. No abnormal signal density noted in. Disc space are normal. In the cord, I don't see any clear hyperintensity within the substance of cord. Thecal space appears unremarkable. So in summary, only a tangle of vessels, especially around the C6 and C7.
Look at the cord again, doctor. Look at the cord again, please.
Okay. Okay. Can I see the axial at that level? I cannot appreciate it clearly. Okay.
Look at the cord again, doctor.
So this cord also is slightly, the cord substance is slightly attenuated at that level with a decreased thickness, so suggestive of malacia of the cord. With adjacent vessels, so in keeping with it appears to be dural AVF with secondary malacia at the cord.
Excellent.
And also
what
in
will
the
you do
lower
next?
cord I can see
what will you do next?
For this I will suggest for a contrast MRI for confirmation and to see any abnormal nidus foci is there. And
okay. How could thank you, doctor. Thank you. Okay. You did very well.
Thank you so much.
This is a case of a spinal dural arteriovenous fistula. The answer from T2. No need, in my opinion, for other sequences to diagnose this case. There are multiple territory here, and mild cord expansion and extensive cord bright T2 signal. Edema. Okay. Why? Why? Yes. Because the venous hypertension. There are venous hypertension, regurg of blood, and like varicosity, any varicosities. So there are edema here, cord malacia, like you said, but better to say this is edema because I think cord malacia should have some atrophy. This is expanded. So this is your first differential would be AV fistula. Okay, what will you do next in this case? We should transfer after confirmation and whatever. I think no need even for post-contrast because from T2 you can diagnose it. We should transfer to neurosurgery or interventional neurologist. Why? Because this case treated by occlusion of the fistula. Okay. This case or this film is an observation film. You did very well. Okay. Thank you.
Yeah. Thank you.
First case.
And
first case here. You did very well, but I will tell you something. We start the examination. You didn't see, suppose you didn't see anything. You told me there are something here. By the way, this is hemangioma. But don't expect FRCR will be about this hemangioma, except if there are aggressive changes here. Doctor, I can't see any intracranial obvious abnormality. I will revise my review area. I wanted to listen from you this buzzword. Okay?
Yes.
Okay. You then I show you. I stop here. If I didn't stop, you will not show it. One of the most important review area, and I think today this is the second case to look meticulously at the skull base. There are signal abnormality here. Okay?
Yes.
So this is dissection. What should you do? First, to confirm T2 fat side. There are no fat side, but this is obvious. This is intramural, high signal, bleeding, hematoma. So this is dissection.
Yes.
What should we do next? We should look at the left hemisphere along the ACA and MCA territory as well. Oh, doctor, there are abnormal signal here in the watershed areas. See? And my colleague, take a home message.
So restriction is there.
Take a home message. In any dissection, check the watershed area. Okay? Why, doctor? It should be an extensive infarction of the affected site. No, don't forget there are circles of wells. Okay?
Yes, sir.
The left the left circulation is retrogradely supplied by the right. But
Yes.
only the affected areas is the watershed areas. The watershed areas is affected in dissection, in hypotension, especially in old age and atherosclerotic or vasculopathy patient. This is between the ACA territory and the MCA territory. So this is an infarction. See, where in the centrum semi-ovale mainly, and a little bit in the corona radiata at the left side. How can we confirm it? See.
Yes.
So take care,
Use
my
right
friends.
ventricular.
Okay, this is very
Yes, sir.
simple but tricky film. Thank you, doctor, so much. You did
Yeah.
very well.
Yeah.
Thank you.
Thank you, sir.
Welcome. And one point, one very important management. The dissection should be
Yes.
managed urgently
Manage
by
urgency
interventional
room.
radiology, interventional neurologist, because it is, يعني if it is treated as early as possible, the patient will, يعني, the complication will be less.
Yes.
Okay, my colleagues.
Thank you.
Welcome. Next candidate.
Assalamu alaikum, sir.
Salam. Female patient, 50-year-old, trauma from motor vehicle collision and not responsive. Means comatose.
Right. So these are axial CTs, axial and
No.
sagittal.
Yes.
Yeah. So sagittal CT images of the cervical spine and base of skull. Yeah, please. And I can see the NG tube. Anteriorly, there is lucency seen in the spinal canal, in the cervical level, and posteriorly in the soft tissues. I cannot. There is no clear discrete fracture seen. There is some scalloping anteriorly in the 5-6 vertebrae. Can you please scroll?
No scroll. The most critical results are here in this slide.
So there are air lucencies anteriorly in the prevertebral tissues and the.
Don't worry about it. There
the
are
spinal
something very critical here.
Sir, I'm looking at the. So there must be a fracture because of which there is the air lucency.
Okay. Where is C1 vertebrae?
Oh,
where
yes.
is C1?
Sorry, sir. Yeah. The C1 is not clearly visualized.
Okay.
And there is some architectural distortion at the. Yeah.
Yes. See the relation here, the distance here. Look at the distance, please.
Yes, so the distance from the base of the skull and the C1 has increased.
So
there is there is a so there is transaction of the
transaction.
Yeah.
What is the diagnosis? When we see the distance is enlarged or increased. Correct. Yeah. This. Yes.
This is the transaction at the base of.
Not transaction. There are a separation here. What is the name of separation? This. So.
Sir, I cannot think of it right now.
No problem. Okay. Increase the distance between the skull base and T1. Excellent. What else?
Sir, I'd like to see the MRI spine to look at the spinal cord.
Unfortunately, there are no MRI. Look here. There are any fracture here?
Yes, there is a fracture of the C2.
This is C1, but see, C1 is fused with C2. Right. What about the area you told before? Where is it?
So, sir, this is seen in the spinal canal. This looks extra dural.
Excellent. See here. Yeah, let's see the soft tissue window.
Yes, sir. So ETT and the NG tube is seen, and the axial images show.
See here, there are something soft tissue inside the canal. What
Yes,
do you
sir.
think in trauma?
So
What should be? What is the cause here?
so there is a fracture of the C1.
Excellent. So finally, your diagnosis. Tell me.
So the Jefferson's fracture.
Not Jefferson. This is something more severe. Tell me, even you don't know the name. The most important, this distance increased or decreased?
Yeah, the distance is increased.
Increased. So there are
Yes,
dissociation.
sir.
There are
Okay.
Atlanto-occipital dissociation. Excellent. Next case.
Yes,
I
sir.
think we did this one. So.
Yes, sir. It was done previously.
70-year-old male patient with progressive headache for 2 weeks and frequent vomiting for 3 days.
Right. So this is axial CT brain, and this is
Yes.
venous phase.
Yes.
And it shows a
Venous
hyperdense
phase?
area in
Are you
the.
sure? Are you sure
Yes,
this
sir.
is venous phase?
Oh, sorry, sir.
This is venous?
So this is non-contrast.
Yes, excellent.
And it shows a hyperdense area in the right centrum semilual with surrounding edema.
Yes.
And also in the contralateral left side as well. So, and it is and there is prominent cisterna magna noted.
Okay.
These are the post-contrast images.
Excellent. What happened in the superior sagittal sinus? This is the normal superior sagittal sinus. Look here.
Yes, sir.
See. This is the
There's a filling
post-contrast.
defect. There is a filling defect
Excellent.
noted in the. Yes, sir. There's a filling defect noted in the superior sagittal sinus.
So, what's your differential diagnosis?
This is superior sagittal sinus thrombosis with venous infarct, bilaterally more on the right side.
Not bilateral, doctor. Not bilateral. Look again here.
Okay.
Almost
yes.
right or left?
This is right.
This is
It's
right.
right, and there was
What is
some
here?
edema on the left.
Yes, thank you, doctor, so much. You did very well in this second case. Don't worry about the first case. All of us have some mental block. My colleagues see this
So
is
this is the
non-contrast.
first time I've tried. This is the first time I've tried the Viva.